You know, usually when we talk about a medical diagnosis or like a clinical procedure, there is this expectation of precision.
Oh, absolutely.
It feels like engineering, right? You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is.
Right. It's binary. It's highly measurable, and I think that gives us comfort. We naturally want our medicine to operate like a well-oiled machine,
Yeah.
where a specific action produces a guaranteed visible result.
But then you step into the world of soft tissue injections.
Yeah, that's where things get complicated.
Exactly, particularly in highly complex anatomical regions. Suddenly, that metaphorical x-ray machine just breaks down completely. We're looking at a clinical landscape that is murky, and that leads us to a tension that is honestly a little unsettling.
It really is.
So for you listening, the mission today is a custom-tailored deep dive into a highly specific, high-stakes medical practice. We are looking at the precise safety checks performed specifically, gentle aspiration before depressing a syringe plunger in vascular dense vulval zones.
Which is a topic that is just fascinating. We are pulling from a massive stack of clinical literature today. We've got peer-reviewed studies on hyaluronic acid fillers. We've got ultrasound biomechanics and gynecological anesthesia protocols.
Yeah, and the hook here, the core tension is that this medical safety check, gentle aspiration, is taught universally. I mean, it is trusted implicitly in medical and nursing schools all over the world.
It's the gold standard.
Right. And yet, according to all this recent data we're looking at, it might actually be giving doctors a dangerous false sense of security.
It is the absolute definition of a clinical paradigm shift. The literature we are looking at forces us to rethink everything from like the basic physics of a syringe to the micro movements of the human hand.
Let's unpack this, because before understanding how to inject safely, we have to understand why this specific anatomical area is so incredibly unforgiving.
Right, the anatomy is everything here. The data focuses heavily on the external genitalia and vaginal walls. And when we talk about the vulval and vaginal area, we aren't just talking about a simple flat layer of skin and muscle.
Not at all.
The anatomical literature describes this entire region as being surrounded by an extensive, highly dense venous plexus.
Basically, an incredibly complex, intertwined network of blood vessels.
It is an incredibly rich vascular bed. And practitioners are routinely performing a wide variety of injections in this space. On the medical and gynecological side, you have the delivery of anesthetics, like lidocaine or ropivacaine.
Right, for numbing.
Exactly. These are used to numb the area for procedures like a manual vacuum aspiration, often referred to as an MVA, which is utilized for emptying the uterus. You also have the pudendal nerve block.
And that's a very specific anatomical target, isn't it?
Extremely specific.
Right.
For pudendal block, the practitioner is navigating deep into the pelvis. They are targeting the space just posterior to the ischial spine, right next to the sacrospinous ligament.
Just trying to visualize that.
Yeah, the goal is to bathe the pudendal nerve in anesthetic to numb the lower vagina and perineum, which is crucial for things like an outlet forceps delivery or an episiotomy. But to do that, they are injecting right alongside the inferior gluteal and pudendal vessels.
So they're right next to the major plumbing. Okay, so that's the strictly functional side. But the sources also highlight a massive surge in aesthetic and reconstructive procedures in this exact same vascular dense area.
Yes, the use of hyaluronic acid fillers, or HA fillers.
Right, so we aren't just talking about facial aesthetics anymore, like lip fillers. We're talking about functional reconstructive medicine, where this is becoming incredibly common.
We are. Hyaluronic acid fillers are increasingly being used for labia majora rejuvenation, or for treating debilitating conditions like vaginal mucosal atrophy, to enhance elasticity and restore tissue thickness.
It's a hugely growing field.
It is. But here is the crux of the issue. Whether you are injecting a thin, watery anesthetic for a nerve block or a thick, cohesive hyaluronic acid filler for reconstruction, the catastrophic risk remains the exact same.
The inadvertent intravascular injection.
Yes.
Meaning the product accidentally goes directly into the blood vessel rather than sitting safely in the surrounding tissue.
Exactly. And what makes this area uniquely unforgiving is that it's highly dynamic. The involuntary muscle movements around the vaginal wall can actually cause filler droplets that were injected safely nearby to be squeezed or migrated into the blood vessels after the fact.
Wow, and an injection gone wrong here is terrifying. It doesn't just cause local tissue death necrosis, which, that's bad enough.
It can get much worse.
Right, the clinical literature actually documents severe pulmonary complications from this. They mention conditions like pulmonary embolism and diffuse alveolar hemorrhage.
Yes, those are the primary catastrophic risks.
Wait, diffuse alveolar hemorrhage? You mean the filler travels to the lungs and actually causes them to bleed? How does a gel from a syringe end up doing that?
It has to do with the specific venous return pathway from the pelvis. The veins in the vulval plexus connect to the internal iliac veins, which feed into the inferior vena cava.
The major vein returning blood to the heart.
Exactly. That large vein goes straight up into the right side of the heart. From there, the heart pumps that blood directly into the pulmonary arteries, which branch out into the delicate capillary beds of the lungs.
Oh, wow.
So if a cohesive plug of filler gel gets into a vulval vein, it rides that highway straight to the lungs. It physically blocks those microscopic capillaries. Pressure builds up behind the blockage until the delicate air slacks the alveoli. They simply burst.
And that is the hemorrhage.
That is the hemorrhage.
Listening to this, the image I'm getting is it's basically a densely packed minefield. You make one wrong step or your needle is 1 millimeter off, and it's not just a localized explosion. The whole thing sets off a chain reaction that travels straight to your lungs.
That is a very apt way to visualize the stakes. It's high risk.
So if 1 millimeter of movement means the difference between a successful procedure and an embolism, how on earth are doctors making sure they are in the right spot before they push the plunger? I mean, there has to be a standard protocol.
There is, and it brings us to the medical world's traditional gold standard of defense, the technique known as gentle aspiration.
Okay.
This protocol has been codified and taught for decades. The mechanics basically work like this. Once the needle or cannula, which is often a tiny 25 gauge to 30 gauge size, is placed into the tissue, the practitioner stops entirely.
They just freeze.
Right. Before depressing the plunger to inject the product, they apply negative pressure by pulling back on the syringe plunger.
And according to the clinical guidelines, like the 10-point plan 2021 for procedural safety, they are supposed to hold that negative pressure for about 5 to 7 seconds, sometimes up to 10 seconds, right?
Exactly. The goal of pulling back is to look for a flashback or a positive aspirate of blood entering the hub of the needle or the barrel of the syringe.
So you're literally just looking for red.
Yeah. If any blood appears, it tells the practitioner that the tip of their needle is currently sitting inside a blood vessel. They immediately halt the injection, withdraw, and they have successfully averted a crisis.
Along with other visual checks, right? The guidelines also mention being acutely aware of the bevel angle of the needle, like whether it's inserted at a 45-degree angle versus perpendicular to the tissue.
Yes, depth and angle matter immensely.
And watching the skin closely for early, fleeting blanching, which means the skin turns suddenly white because the blood supply has just been compromised.
Visual cues are definitely part of it, but the aspiration itself, that physical pullback, is treated as the ultimate diagnostic test.
The final say.
Right. If they pull back, wait the required time, and there is a negative aspiration, meaning absolutely no blood enters the syringe, the training dictates that it is perfectly safe to go ahead and depress the plunger.
Okay, I want to pause here because on the surface, this makes total rational sense. It feels like basic plumbing to me.
It really does.
If I have a pipe in my house and I pull a vacuum on that pipe, wait 10 seconds, and pull absolutely zero liquid out, well, basic physics says the pipe is dry. By that logic, if there's no blood on the pullback, you are 100% safely outside the vessel.
And that is the exact logical assumption the medical community has operated on for years. It appeals to our desire for binary, measurable safety.
Sure.
But the human body and the rheology, the flow mechanics of these tiny syringes and thick gels, they do not behave like rigid household plumbing.
They're not copper pipes.
Exactly. And the latest experimental data is aggressively dismantling this assumption. Let's look at what the literature calls the primed needle problem.
Right, because when a practitioner is injecting a filler, the needle isn't empty before it enters the skin. It is primed, meaning it's already full of the product they intend to inject.
Yes.
The 2015 experimental study by Carey and colleagues specifically tested this, didn't they? They wanted to see if blood could actually be aspirated into a syringe that was already packed with thick hyaluronic acid filler.
The findings were alarming. They discovered that the filler itself acts like a physical cork. Yeah. Needles that are primed with a highly cohesive dermal filler often block the blood from entering the syringe entirely. A practitioner could be sitting directly inside a vein, pull back the plunger, and get a completely negative aspirate.
Wow.
The filler is simply too thick and cohesive to allow the low-pressure blood to push past it and enter the hub.
Hold on, I want to make sure I'm getting this. If the needle has filler in it, the blood just gives up. Shouldn't the blood pressure be strong enough to push a little bit of gel out of the way? I mean, we just talked about how arterial pressure pumps blood all over the body.
You would think so, but it comes down to the gauge of the needle and the physical properties of the gel.
Okay.
When you have a highly viscous, cohesive gel packed into a microscopic tube like a 27-gauge needle, the surface tension and friction are just immense.
It's jammed in there.
Exactly. The negative pressure created by a human hand pulling back on a tiny plunger is often not enough to overcome that friction. And the blood pressure knocking at the tip of the needle certainly isn't enough to dislodge the plug either.
That's why.
And this phenomenon was corroborated in a fascinating 2021 in vivo study by Moon and colleagues.
That was the one using animal models, right? Rabbits, I think.
Yes, they wanted to test this in live physiological conditions,
Yeah.
complete with a beating heart and actual blood pressure.
Real world condition.
Exactly. When they primed the needles with just air, or a thin watery fluid like saline, and pulled back while inside a blood vessel, they get an immediate flash of blood. The test worked perfectly.
Okay.
But the moment the needle was primed with a dermal filler, the risk of a false negative skyrocketed. The blood simply could not break through the product.
So the very product you were trying to inject safely is the exact thing sabotaging your safety check.
Exactly.
But the studies go further than just the thickness of the gel. There is also the issue of time and pressure.
Yes, the 2017 Van Loghem study is brilliant for exploring this.
What did they do?
The researchers wanted to simulate real arterial blood pressure as accurately as possible. To do this, they took bags of fluid and blood and pressurized them to exactly 150 millimeters of mercury.
Which is pretty high.
Right, this perfectly mimics the pressure of a major facial or pelvic artery. Then they took filler-primed needles, inserted them into this high-pressure system, and attempted to aspirate.
And this is where the rapid-fire nature of actual clinical practice crashes into laboratory theory.
Exactly.
Because they found that if a practitioner does a quick 1-second pullback on the plunger, which, let's be honest, is what a lot of rushed injectors actually do in the real world, it resulted in a 67% false negative rate.
Yes, 2/3 of the time.
2/3 of the time, they were sitting directly in a simulated high-pressure artery, pulled back for a second, saw absolutely no blood, and would have just proceeded to inject.
It exposes how incredibly fragile the safety margin is. And the study noted that even when they held that negative pressure for a full 10 seconds, false negatives were still incredibly common, particularly depending on the manufacturer of the needle.
Let's talk about holding a needle for 10 seconds. Because in a real-world clinical setting, holding a tiny needle perfectly still inside a living, breathing patient for 10 full seconds while simultaneously applying strong backward force on a tiny plunger sounds incredibly difficult.
It is functionally impossible.
Yeah.
Which brings us to the most damning evidence against the aspiration technique, the micro-movement problem.
Right. The Griffith University ultrasound study. They used real-time ultrasound imaging to physically track the tip of the needle inside human tissue while the injector was performing the aspiration tests.
This study completely changes how we view needle stability. I mean, the entire philosophical premise of the aspiration safety check requires absolute stillness.
Because you need to inject in the same spot you checked.
Exactly. The logic is you pull back to verify the location.
Yeah.
If it's safe, you push forward to inject in that exact same verified location.
But the ultrasound proved that absolute stillness is a total myth, right?
It is. During the physical act of pulling back the plunger, the aspiration phase, the needle tip involuntarily retrogrades, or pulls back, between 1.1 millimeters and 5.3 millimeters in the tissue.
Wow.
And then, when the injector shifts their hand to push the plunger in for the actual injection, the needle tip surges forward again by 0.6 millimeters to 4.1 millimeters.
So you're just sliding all over the place.
Yes. We have to ask why this happens. Think about the biomechanics of your hand. You're holding a tiny plastic cylinder. To pull back that stiff plunger and create a vacuum, you have to exert physical force with your thumb while stabilizing the barrel with your fingers.
That makes sense.
That muscular tension naturally creates a tremor or a shift. The researchers noted that even highly experienced injectors using a strict double-handed stabilization technique where they brace one hand firmly against the patient just to hold the barrel still and use the other hand solely to pull the plunger still experience these significant micro-movements.
I mean, just trying to visualize this, it's basically trying to thread a needle on a moving train.
That's a great way to put it.
And the anatomical context makes this terrifying. The blood vessels we are trying to avoid in the vulva are often only 1 to 2 millimeters wide.
Right.
So if your needle shifts 5.3 millimeters just from the tension in your hand when you pull back, you could do your safety check, get a perfectly accurate negative reading because you have pulled the needle safely outside the vessel.
Yes.
And then, in the fraction of a second it takes to shift your grip and push the plunger, your hand lurches 4 millimeters forward right into the 2 millimeter blood vessel you were trying to avoid.
Exactly.
Yeah.
You have accidentally caused an intravascular injection
Yeah.
because of the movement generated by the safety test itself.
That is deeply ironic.
It is. And keep in mind, these ultrasound tests were conducted in ideal, relaxed laboratory conditions.
Hmm.
Add in a clinical environment where the patient might flinch, take a deep breath, or shift their hips slightly, and those tissue planes are moving even further.
Okay, this feels like a massive problem. If holding still and pulling back is, as one of the papers bluntly calls it, an exercise in futility, what are the actual safety checks? If the plumbing analogy is broken, how do practitioners safely navigate these vascular dense zones before depressing the plunger?
The paradigm shift requires abandoning the illusion of stillness. What's fascinating here is the psychological danger of a negative aspiration. It gives the injector a false sense of security.
Because they think they're clear.
Right. When they see no blood, it encourages them to confidently push down on the plunger and deliver a large, static bolus of product.
And a static bolus just means injecting a large amount of fluid into one single spot without moving the needle, right?
Yes. If you think you are safe, you just deposit a big lump of filler or anesthetic. But if your needle has microshifted into a vessel without you knowing, that static bolus acts as a massive embolism.
It just plugs the whole thing.
It completely occludes or blocks the entire vein or artery. The paradox here is that true safety doesn't come from remaining perfectly still. It comes from continuous movement.
So you are saying they should be moving the needle while they are injecting the product.
Exactly that. If a practitioner keeps the needle or cannula constantly moving through the tissue while applying pressure to the plunger, they drastically mitigate the risk.
How does that work?
The techniques are referred to as retrograde or antegrade filling. Retrograde means you are injecting a trail of product as you slowly pull the needle out of the tissue.
Okay.
Anterograde filling means you are injecting a tiny amount of product continuously as you slowly push the needle forward.
I see. Because if you are constantly moving the needle, even if the tip accidentally crosses directly through a blood vessel for a split second, you are only leaving a tiny microscopic droplet of product inside it before the needle exits the other side of the vein.
Exactly. And those tiny microscopic droplets are too small to cause a massive blockage. They simply wash away and dissipate harmlessly in the general circulation. Movement equals safety.
That completely flips the traditional script. And I imagine there are other crucial protocols that go hand in hand with this continuous movement. I mean, you can't just be wildly moving a needle around and slamming the plunger down.
No, absolutely not. The clinical guidelines pair continuous movement with extremely slow injection speeds and very low extrusion force, which simply means pushing the plunger incredibly gently. You never force the product.
Slow and steady.
Always. You also transition to using microboluses instead of large deposits.
The literature gives a great example of this with the deserial injection protocol, right? Which is specifically used for treating labia majora hypotrophy and restoring vaginal mucosa.
Yes.
Instead of using a sharp needle, which slices through tissue, the protocol highly prefers a 25-gauge, blunt-tipped cannula.
Right. A cannula is essentially a flexible tube with a rounded tip. It is much preferred in these high-risk areas because it tends to glide past blood vessels or gently push them aside, rather than piercing directly through them like a sharp, beveled needle would.
And the protocol dictates that the practitioner must stay strictly in the safe submucosal plane. They keep the cannula moving constantly, and they distribute tiny microboluses of just 0.05 to zero point 0.1 milliliters of product at a time.
Which is an almost imperceptibly small amount of gel.
Right. And then after delivering these tiny trails of product across the targeted areas, the practitioner stops injecting and relies on gentle manual molding with their fingers to ensure the product distributes evenly into the desired shape.
Exactly. They aren't trying to inject a large, perfectly shaped volume all at once from the syringe.
It makes a lot of sense when you break it down like that.
It highlights how real safety in these highly vascular zones doesn't come from a single mechanical test.
Yeah.
It comes from a deep, almost three-dimensional knowledge of the anatomical layers, combined with a dynamic, highly controlled injection technique.
You have to respect the anatomy.
You have to respect the tissues, respect that vascular minefield, and rely on constant movement, slow speeds, and microdosing.
So, bringing this all together for you, gentle aspiration, that classic pullback to check for blood, is still going to be taught. You will still see it practiced in clinics and hospitals, especially in procedures like pudendal nerve blocks.
Yes, it's not going away entirely.
Because in those cases, they are using thinner, watery anesthetics where the prime needle plug effects isn't nearly as severe as it is with thick HA fillers.
Right, it remains part of the clinical vocabulary.
Okay.
But the latest data heavily suggest it should never be solely relied upon as a guarantee of safety.
A negative aspirate simply does not mean you are in the clear.
No, it's just one tiny piece of data at one exact millisecond in time. And as the ultrasound shows, the next millisecond could be entirely different.
Real safety in the vulval zone, or really any vascular dense area, comes down to keeping the needle moving, injecting incredibly slowly, and keeping the volume tiny.
It serves as a perfect example of how clinical medicine has to constantly evolve. As our diagnostic tools like real-time ultrasound get better at showing us what is actually happening beneath the skin, we have to be willing to update our fundamental practices.
Which leaves us with a lingering thought to chew on. We started by talking about the X-ray, the deep human desire for clear, binary safety checks.
Right.
But if a cornerstone, universally taught medical technique like aspiration can be proven by modern ultrasound to be biomechanically flawed simply because human hands and human tissue involuntarily move a few microscopic millimeters, it really makes you wonder.
It really does.
How many other foundational gold standard medical procedures are out there right now relying on theoretical safety instead of real-world physics?
It forces us to ask how often we mistake a comforting, familiar ritual for actual clinical safety.
The waters are muddy indeed. Thanks for exploring this with us.